Good morning, everyone, and welcome. On behalf of WHO, I'd like to welcome you to the second day of the session that we're organizing. So today, yesterday we focused on polio and polio eradication. Today, we really want to look at how can we broaden that agenda and what are the linkages between polio eradication, immunization for polio, the broader immunization agenda, but also linking up to other services for mothers and children. We really want to look at what is the power of prevention, looking at other preventive measures that we can have, and then look at the second panel that we'll have more in detail on what do we have to do for newborns, what do we do for early childhood development, what do we do for maternal health, and see how those linkages fit in with the work that has already been supported so much by the Rotary itself. So we have a two-day program for today. In the morning, we'll have a couple of panel sessions, two panel sessions with speakers who will highlight this kind of transition in thinking from polio eradication towards a more holistic maternal child health focus. And then in the afternoon, we're going to have presentations. We'll have 3 breakout rooms where we'll have 10 presentations or 11 presentations each, looking really at specific projects that have been implemented globally, most of them through Rotary clubs themselves. And we really would like to use that as a kind of cross-fertilization between different Rotary districts, Rotary members, to learn from each other what is possible, what has been implemented globally, and how can other districts pick up on those kind of ideas and see whether they can implement similar kind of ideas in their district. So that's really the afternoon session. Short presentations of 10 minutes each by different speakers of projects. For the morning, we would really like to highlight, let's say, what this transition actually means. And we have a wonderful set of panel speakers in 2 panels. And so I hope that you'll all find it very engaging. I also want to welcome everyone who's online. We have a full house here in the auditorium, let's say, but we have people online as well. So I want to welcome everyone online who's listening in as well to this wonderful day. Pierre, over to you.
Thank you very much, Andrew. Yes, it's going to be a very interesting day, and we will talk a lot, at least in the morning, about theory. And as you know, you probably don't know, I'm an orthopedic surgeon, and I see polio from the other end. Here we do vaccinations, millions of people, and public health and all that, and it's very interesting, except that we see the patient the way he presents himself at the end. And I would also like to change your view of the patient. We all see children that have suffered and that have paralysis, but then what happens? Because that's the thing. So the children overcome their handicaps. Most of the time, they have a fantastic and a very productive life. And then things happen as they get older. And I've brought today Flaminia Del Balzo, who is a patient I've been following for now many years. And Flaminia has agreed to come and tell her story a little bit. So I'll just hand over to you, and maybe can we start the slideshow, please?
Mesdames et messieurs, bonjour. Je m'appelle Flaminia Del Balzo di Presenza.
Good morning. I am Madame Flaminia Del Balzo. I was born in Italy in 1952, and at 10 months, I got polio when I was on holiday in the north of Italy. I came from a privileged family, and I had a good follow-up, but it's also the fact that I had all this help did not mean that I did not have difficulties during my life. During a school visit, I had also bullying issues when my friend tried to drown me in a pool, and I had a lot of difficulties on a physical and psychological level. When I was young, they used to ask me what was wrong with my leg, and I had I could not say that I had had polio, and I also always said that I had fractured my leg, but at that moment I had no fracture. Fortunately, no more questions used to be asked. I managed to lead a normal life. I worked, I married, I have 3 children, 7 grandchildren. I practice sport, and despite physiotherapy and all the therapies, after years, weakness in my muscles on my left leg appeared, and this led to around 10 fractures around the ankle and different parts of the leg. And this was difficult. Polio impacts the person all over, psychological, physical, and on a family level as well. I have a Peruvian friend, for example. The father and her sister died of polio. Her father did not want to vaccinate the child. I know a young mother who did not want to vaccinate her 2 young children. And this is, and it's only my experience which may manage to convince her. I think that we need to do our maximum in order to ensure that polio vaccination is accessible to all and to have efficient campaigns in place. The fact that you're trying means that you're making the world a better place, and this is amazing. Ladies and gentlemen, I would like to thank you for your attention, for your patience, and I must admit that this is the first time that I'm talking in public about this, but also in my life about polio, because even within my family it was a taboo issue. So I had to take Obelix's magic potion in order for me to have enough courage to be there. Thank you very much.
Thank you very much for this very moving testimonial, and I think this is what it's all about, and this is why we're all here. Could I just have the slideshow, please? Okay, next slide. Okay, next slide. Next one. See, this is the idea we have of polio, right? Next one. You just heard the testimony. Next one. We just heard Flaminia tell us about her life. Next one. Next one. So what happens? You have polio, you have muscle atrophy, and then osteopenia comes in. That means your bone gets fragile. And what happens is falls. Next one. And so these are all the fractures, and I'm probably missing some of them. I don't think I have every single one, but you can see that starting a certain time in life, this happens. Next one. And, you know, being an orthopod, I just have to show you the x-rays. And you can see there's a lot of metal in that leg, but it's a lot of suffering. And it's every one of these operations is a big deal. Next one. So these are the consequences of polio, and this is why we have to vaccinate people, and this is why we're here. And thank you, Jennifer Jones, our president. And our Director General, Dr. Tedros from the WHO, for leading this charge, and we have to keep on going. So thank you very much, Flaminia. I think next speaker will be John Hugo. John Hugo has served as Rotary International General Secretary and Chief Executive Officer since 2011. He's a charter member of the Rotary Club of Kiev, Ukraine. Hugo lives out Rotary's mission, whether inside or outside the office. He's immunized children against polio in India, represented Rotary at the World Economic Forum, bicycled 104 miles with Rotary members in Arizona. Must have been warm. And to help raise over $50 million for polio eradication. Thank you very much, John Hugo.
Thank you. Thank you so much, Pierre and Flaminia. Thank you so much for sharing your polio story with us. And as you mentioned, Pierre, when we eradicate this disease, and we will, no one will have to, again, go through what Flaminia and other polio survivors have had to endure. So again, thank you to everyone for your support, our incredible support to eradicate this horrific disease. Now, this morning, I'm pleased to talk to you today about one of the most important partnerships for Rotary, and that is our longstanding and continued alliance with the World Health Organization. Global health challenges, as we all know, are large, they're complex, and they're borderless. And as we've seen with the COVID-19 pandemic, there's no one simple solution to any health crisis. And we can't make lasting progress on these challenging and difficult tasks in isolation. And so the greatest impact demands deep and wide partnerships that will harness all the resources that are available. And Rotary understands how indispensable such partnerships are, and we appreciate very much the value of global leadership in these very, very important efforts. And so that's why Rotary was advocating for the creation of WHO's parent organization even before the drafting of the United Nations Charter. During World War II, Rotary informed and educated members about the formation of the United Nations and the importance of planning for peace. Rotary leadership communicated to our members how the United Nations would relate to Rotary's goal of advancing international understanding, and emphasize the importance of having a plan for when the war ended, rather than waiting for the fighting to stop. And so when the war did finally come to an end, Rotary was invited to serve as consultants to the United States delegation at the San Francisco conference, which led to the drafting of the United Nations Charter. In fact, there were 11 Rotarians that participated in the United States delegation, and overall 49 Rotarians participated in the delegations of all the various countries at the 45 Charter event in San Francisco. And today, Rotary holds the highest consultative status offered to a non-governmental organization by the United Nations Economic and Social Council. And each year at Rotary Day at the United Nations, we celebrate our shared vision of peace, and we highlight the critical humanitarian activities that Rotary and the United Nations lead around the world. Now, our specific relationship with the World Health Organization can be traced to 1988. That year, the World Health Assembly adopted a resolution calling for the worldwide eradication of polio. And that marked the creation and the launch of the Global Polio Eradication Initiative that included the U.S. Centers for Disease Control and Prevention, UNICEF, the WHO, and Rotary. And then later we were joined by the Bill and Melinda Gates Foundation and Gavi. WHO has really been an incredible, remarkable partner in this effort, coordinating the strategic planning, management, and administration processes of GPI. WHO is responsible for the systemic collection, collation and dissemination of standardized information on strategy, implementation, and impact, particularly in the areas of surveillance and supplementary immunization activities. WHO also coordinates operational and basic research, provides technical and operational support to ministries of health, and coordinates training and deployment of technical assistance. And in addition, WHO leads on ensuring certification standard surveillance. And so, in addition to all of this truly incredible and remarkable work, WHO is always willing to take an extra step to advance global health progress when it's needed most. And this has been demonstrated time and time again in polio eradication. In 2012, former Director General of the World Health Organization, Margaret Chan, advocated strongly for the World Health Assembly to declare the completion of polio eradication to be, quote, a programmatic emergency for global public health. She said, polio eradication is at a tipping point between success and failure. We are in emergency mode to tip it towards success, working faster and better, focusing on areas where children are most vulnerable. The Assembly approved that emergency declaration, and the results have been striking. Less than 2 years later, India and the entire Southeast Asia region was declared polio-free, and just 2 years ago, the continent of Africa achieved the same status. When Dr. Tedros took over as Director General of WHO, he took his first trips to Afghanistan and Pakistan to see for himself what he called the last frontier of the wild polio virus. And during that trip, he said, "We're so close to ridding humanity of this disease, and I'm personally committed to ensuring that we do so." But when I think about one of the best examples of how closely aligned our two organizations are, I think of the story of Michelle Zafran. For nearly 5 years, Michelle headed up the WHO's polio eradication efforts. And inspired by his work with Rotary, Michel joined the Rotary Club of Gex-Divonne, France in 2017. And shortly after his retirement from WHO in 2021, he was appointed as a Rotary End Polio Now coordinator. His example demonstrates ways the WHO and Rotary can work together beyond programmatic goals, beyond the big picture of eradicating polio, where we can work together on the human level to meet shared goals. And as we've seen in the battle against COVID-19, we see that our organizations can align to help battle vaccine hesitancy and improve health outcomes globally, even in the most challenging circumstances. Challenges remain in the battle against COVID-19, but as we learned in our efforts to eradicate polio, the only effective response to this challenge is a continued determination to succeed and a relentless effort to apply lessons learned to future strategies. And beyond COVID and polio eradication, there is a tremendous alignment between the 2030 Sustainable Development Goals of the UN and Rotary's 7 areas of focus. And at the heart of these goals is a highly ambitious UN goal, known as the 3 billions. It consists of 1 billion more people benefiting from universal health coverage, 1 billion more people better protected from health emergencies, 1 billion more people enjoying better health and well-being. Now, you can look at that number and see something daunting and perhaps unattainable, impossible to achieve. But consider what the GPEI has done over the past 35 years, reaching 3 billion children worldwide with the polio vaccine. And then you realize that we already have a proof of concept. We know we can reach these massive numbers if we have the determination, strategy, and resources to succeed. And so I want to close by saying something about those resources. You know, there's been a great deal of focus lately on the massive price tag associated with reaching all of the UN SDGs. One recent report said that it could cost a staggering $135 trillion. Now, clearly, no one's stepping forward to write a check for that amount. But we must find innovative ways to make progress on these goals in the most cost-effective ways possible. And everyone must be part of that effort. Governments, NGOs, charitable foundations, and volunteer organizations. And the power of that last group can be seen in a recent study. The Johns Hopkins Center for Civil Society recently found that a very conservative, this was a conservative estimate of the number of volunteer hours worked by Rotarians every year around the world, pointed towards $850 million a year in economic impact for that volunteer work. And coupled with the money that we raise through the Rotary Foundation and the money that our clubs raise locally and spend locally, we've estimated that the global annual impact of Rotary is more than $2 billion a year. And that's just one organization, although admittedly one of the biggest and best organized. But when you see the cumulative effect of Rotary service on an issue as big and complex as polio eradication, you see that even this large number, $135 trillion, doesn't begin to assess the impact we can have on the world if we all work together. And by eradicating polio, we will prove that no challenge is too large, and the no price tag should dissuade us from doing what is right. That is why great organizations like the World Health Organization partner with us, and why people like Michelle Zafran join our organization. It's why we remain committed to service above self and creating the greatest impact across the globe by taking on the biggest challenges. So we're grateful for the World Health Organization's partnership in these efforts, and we look forward to a future of many, many shared accomplishments. Thank you very much.
Thanks very much, John, for highlighting that relationship between Rotary and WHO, and particularly how that, for example, is personalized in the example that was brought out there about Michelle Safran. We were now going to see a video about Pakistan. So can we have the video on?
My name is Dr. Sophia Yunus. My title is Director General for Federal Directorate of Immunization, and this is the lead of National Immunization Program.
Has been removed. The gender barrier has been removed. To be able to be here as a woman and to be able to meet with the frontline female health workers, to say two simple words to them: thank you.
Thank you. On behalf of the PI program, thank you.
My name is Zainul Abidin Khan. I'm here working as a national team leader from WHO Polio program.
Today, we're going to talk about the gender strategy and the importance of this to the polio program. Dr. Sophia, let me start with you first. You've been in the immunization world for a number of years. Is this changing the way that we're able to approach polio?
We found that females were reluctant to be vaccinated by male vaccinators. In every strategy we make and in every activity that we conduct, we ensure that females are part of it. We are enlisting people for promotion, recruiting through headhunting. In immunization program, it started in 1974, and since then the national immunization head was never a female, but my presence speaks it all.
Dr. Zain, as one of our partners, what does it mean from WHO's perspective?
As we follow the GPI strategy and WHO policy to always empower the women leadership. So I have the opportunity as a team leader of WHO. I have a huge team here, and I have the opportunity to actually exercise this policy.
So you're showcasing leadership at the organizational level. We now see leadership coming up from the grassroots. And what do you think the role of female frontline health workers means to our eradication efforts?
As we are heading towards eradication, there are still communities that require female frontline workers. We are trying to get more of them, because most of the female workers, when they are going into the community, they need to be secure. So recruiting couples so that the wife and husband or brother and sister, they go together. So for such conservative societies where we struggle, both in terms of female vaccinators or the social mobilizers.
Dr. Zain, this is about changing culture, isn't it? And certainly culture in this nation. It's not easy, but are we taking enough steps so far?
Yes, you rightly said it's not easy. And this culture of this country is not easy to change overnight. But this polio program gave us some opportunities. And in this culture, the men are not allowed to go inside houses. So this is giving us opportunity to introduce female more in the team.
The EPI, the expanded vaccination program, and a gender balance is going to benefit from this because there's so many other immunizations that we need to be able to reach. How do you see that affecting what your work is, what's happening in your work?
We recruited a number of vaccinators, and we have asked the province to please let us know if you need additional workforce. UNICEF provided us with an opportunity to recruit 250 vaccinators, and out of that, almost all were for female vaccination.
Last thing I want to focus on right now is certainly part of the partnership, but what role do you see Rotary playing in the eventual victory as we cross the finish line in eradicating this disease?
So first of all, Rotary is part of Immunization Technical Advisory Group, which is called at NICC. Dr. Aziz Maiman is a part of that. The level of advocacy and the level of penetration into the top government leadership that Rotary brings in, every community level, and the positive energy they bring into international and polio. So Dr. Zain.
I've been working for polio since year 2000, and I worked in several countries, including India, Nigeria. Personally, I believe that we are trying to fulfill the dream of Rotarians to see this world without polio. The support of Rotarians, not only here, everywhere I saw, is more than a partnership. It's generous, and they never say no.
Thank you both for your time, and thank you for your leadership and everything that you bring to this effort. It is immensely appreciated, and my sincere gratitude to you both.
Thank you, and thank you for your time, and we really appreciate Rotary International's contribution to polio eradication initiative of Pakistan. Thank you.
Thank you.
That was really a wonderful video showing that women are at the heart of polio eradication. So we'll now go to the first speaker about the beyond. Yesterday we spoke about polio eradication. Today we really want to touch on the beyond polio eradication. And we'll have Stephen Laurier, who is the Director for Polio Eradication at UNICEF, who is going to kick us off. Stephen's international career covers over 25 years in a variety of functions and contexts. He, until recently, has been the senior advisor for UNICEF's emergency operations. And from 2019 to 2021, he led the humanitarian review team that conducted an in-depth review of UNICEF's humanitarian action and formulated a set of key recommendations that is reshaping UNICEF's humanitarian capacity globally. Stephen also served with the organization in Iran and started his UNICEF career in southern Somalia. Stephen, over to you.
Yeah, and I've been working as well in quite a lot of conflict and humanitarian crises as representative and deputy representative over the past 20 years. But thank you for inviting me again this morning and spending some time with you. There's a link with polio, but we also look to the future, and I'm going into the details of the power of vaccines. And let's put the presentation on. There we go. Next slide, please. Next slide. Just I'm quickly going to go over the power of vaccines, supplying vaccines, and promoting vaccine demand and acceptance. I'm going to make a link to polio, but also looking at the broader perspective here. Next slide, please. Next slide. Yeah, okay. Well, just the figures alone speak for itself. Immunization averts an estimated 2 to 3 million deaths every year. We don't have to say more. Next slide, please. So I think if we look at public health, vaccines are probably the greatest discovery we have made. Since Edward Jenner first smallpox vaccine in the 1700s, vaccines have saved hundreds of millions of people globally from sickness and death. And between 2000 and 2019, we saved 37 million people from measles, tetanus, and other preventable diseases in 98 countries. Also, we eradicated polio for 99.9% in the past 3 decades with a vaccine. It's also one of the most cost-effective public health interventions. For every $1 invested, we get a return of $26 in low and middle-income countries. The power of vaccine has eradicated smallpox, and we're close to eradication with tetanus and with polio, just to name a few. Let's go to the next one, please. Now, if we look at a vaccine, we have to see that the vaccine reaches people. And the first thing we have to do is supply that vaccine, procure that vaccine, and see that the vaccine gets to the people. The procurement, UNICEF procures yearly about 2 million doses of vaccines, including 1 billion doses for polio eradication. We are responsible for the vaccine supply for the GPI, but also for the vaccine supply for routine immunization, for example, with the inactivated polio vaccine, and supplementary activities that take place. We supply more than 45% of the under 5 in the world with vaccines every year, which is quite a significant undertaking. It's a complex undertaking because it also includes the cold chain, temperature control, transport of vaccines, storage of vaccines, and the delivery to the child in very difficult circumstances. But there is a but. A vaccine alone, if it stays in the vial, doesn't make a change. Next slide, please. We have to see that the vaccine is accepted. And we have seen one of the largest setbacks in childhood vaccination over the past years, with 25 million children not being vaccinated. And vaccine hesitancy is one of the key drivers of these under-vaccination that we've seeing, fueled by vaccine myths, misinformation that we have to overcome. Together with other partners, we try to engage through community mobilizers, but also through digital communication, through social media, to really counter the misinformation that is spreading over the world through different channels. We try to engage on this by an evidence-based approach to really see how we can counter it, and with what information we can engage with communities, engage with individuals through religious leaders, through community acceptance, engagement, through community leaders, through polio survivors, for example, through education, to healthcare institutions. And the media is one of the allies, can be one of the allies in this. We're trying as well to set up a robust system of community engagement on a digital platform, whereby we intercept rumors before they become largely spread and try to counter that information on the digital fora. Next slide, please. We have, in social mobilization and advocacy, we have an extremely good collaboration with Rotary. And I must say it's a strategic collaboration. Rotary really helps us in advocating with national and local governments, because Rotary is so well connected across the world that they help us finding the right person to talk to who can really influence the policies in different countries related to immunization. And Aiden yesterday talked, for example, about Aziz, but we also have Ishak in Afghanistan, who helps us on a daily basis on our interaction with political and economic leaders. It is very important, particularly in the areas we work, where we have hard to reach areas that are affected by conflict, or where we have issues with community engagement and vaccine hesitancy. So through the social mobilization and this advocacy efforts that we're doing together with Rotary, we are building community trust, promoting vaccination and vaccine acceptance, but also improving the community awareness about the advantages of vaccination. I think without Rotary, we wouldn't be able to get there. Next slide, please. Not only will vaccines help us to conquer the last mile in polio eradication, but vaccines will help us save millions of children and adults from other deadly diseases. And as I said before, a vaccine doesn't make any difference if it stays in the vial. It has to get to the children. So guided by our polio eradication strategy and the immunization agenda for 2013, we must really see how we can strengthen the synergies with routine immunization efforts, expand polio plus programs to really look also at the delivery of essential health, water and sanitation, nutrition programs that not only will help polio, but whereby polio will also strengthen other public health efforts. Polio campaigns are already integrated in other immunization efforts, which both help strengthening not only polio, but also other efforts that are taking place. And in a way or another, our efforts will and are strengthening health systems that are crucial to increase the health indicators across the world. So this is a concerted effort where we pave the road as well with our experience in polio eradication that contributes not only to the immunization agenda, but to the public health agenda at large. Thank you.
I would like to thank very much Stephen Bavarier for this magnificent presentation of the efforts of UNICEF. And again, polio is not just one man's victory. It's a huge team effort across the whole planet. So thank you very much, Stephen. It's my privilege to present to you Dr. Kate O'Brien. She is Director of Immunization at the WHO. Dr. Kate O'Brien is Director of the Immunization, Vaccines and Biologicals Department at the World Health Organization. In this role, she is responsible for leading WHO strategy and implementation to advance the vision of a world where everyone, everywhere, at every age, fully benefits from vaccines for good health and well-being. Dr. O'Brien is a Canadian, I think that would speak to our president, who trained as a pediatric infectious disease physician, epidemiologist, and vaccinologist. So it's our privilege to present to you Kate O'Brien. She will be presenting on video.
Thank you so much for that very generous introduction. And I'm really privileged to be here with you today. And I'm sorry I'm not there in person. We were convening in another location, in fact, to talk about equity and among the partners, how to do more to assure equity at the country impact level. And so it's a really nice opportunity also to be here in this privileged environment with all of you from Rotary, who play such a critical role in achieving the ambitions and the goals that countries have. So if I can ask for slides to come up, what I'd really like to do is draw on the presentation that was just made about the critical nature of vaccine supply and all of the elements that are needed to achieve impact of these amazing life-saving products that we all have available to us. And I'll go to the next slide, please. What I really want to speak about is this idea of immunization plus and how to build immunization to have a more preventive medicine program for and in lower and middle income countries. And really what we're talking about is primary health care. As I think everybody knows, the immunization program is at the heart of primary health care in every country around the world. And it's that sort of core of the onion building on the immunization program that is such an important driver of primary health care. Next slide, please. In our latest estimates, there are 4 to 5 million children, and this excludes the impact of COVID vaccine globally, but children and adolescents and adults whose lives otherwise would be ended in any given year. Because of vaccine-preventable diseases, those lives are saved. And we are really, really dismayed and in a sort of shocked and shocking position where for the past 2 years, there has been an unprecedented backsliding in the essential immunization program. And that means in this slide, you see, sorry, if we can just go back a slide, you can see in this slide, the past 2 years where we've gone from 86% coverage of the third dose of DTP3, which is our basic measure of the achievement of an immunization program, down to 81%, which means that there were 25 million children in 2021 alone who were either under-vaccinated or completely unvaccinated. In fact, most of that 25 million number, 18 million of those children didn't receive a single dose of vaccine, not one dose of vaccine through the routine immunization program. And that's 6 million more children than suffered that situation in 2019. Next slide, please. We call those children, those 18 million children who don't receive even one dose of any vaccine through the routine immunization program, we call those children zero-dose children. They receive 0 doses, and they're a marker of marginalized and missed communities. It's not just children who don't get vaccination. The 2 out of these 3 zero-dose children live in households that are surviving on less than $1.90 a day. They are the poorest of the poor. Among these children also, 47% have mothers who received no antenatal care, no skilled birth attendants. And they're not randomly distributed. There are equity issues here. Ethnicity plays a big role and is a determinant of these zero-dose children. And just one example shown here in Afghanistan across different ethnic groups, the zero-dose prevalence in those groups. And so these are not randomly distributed children, and they are this marker of communities, families, and areas of countries that are not within the program of protection. Next slide, please. And these missed communities are often the places where outbreaks occur. They're also the least capacitated to detect and respond to them. And so we do see this for yellow fever, measles, meningitis, cholera, Ebola. These outbreak-prone pathogens are the outbreaks that occur largely in these missed communities. And reaching missed communities as a result of that means it's critical for a global health security perspective. And that includes as well reaching the objectives for controlling the pandemic of COVID-19 that everybody in this room, both virtual and real, has suffered through. Next slide, please. So I wanted to show you that not only are the missed communities and the missed children not randomly distributed, but in addition, the countries where these children live are quite concentrated. There are 10 countries that account for the majority of the missed children. And what these bubbles show you are the white part of the bubble is the size of the surviving infants in the country. The colored bubble is sized according to the quantitative number of children who are zero-dose children. And the color refers to the extent of vaccine coverage in that country. And so any one of these countries ends up on the top 10 list for a combination of reasons. Either it's a very large country or there's an attribute about how much coverage there is. It's those two things together. And you can see that we quantify zero-dose children according to, we enumerate them by how many children didn't even get the first dose of their DTP-containing vaccine. That means also that they're not getting their first dose of polio vaccine, because polio vaccine in the essential immunization program is co-administered at the time of DTP1. But there are also other visits that children make for vaccines, and their first dose of measles vaccine doesn't occur until somewhere around 9 months of age. And so there are also children who are what we would call zero-dose children for measles vaccine, one of the most infectious diseases, and a very similar list of countries for being zero-dose for measles vaccine. Next slide, please. I think the slides on my side have stopped moving and are very large now. Thank you so much. So I want to speak about this backsliding and the recovery from the backsliding. And there are enormous country efforts going on right now to recover from the backsliding, to stand up, catch-up campaigns, recovery campaigns, and to advance the routine immunization program. And you'll notice that I sometimes call it the essential immunization program. It does go by EPI. It has been, the term for that has been the expanded program for immunization. And there's a groundswell of renaming this program, because the term routine immunization, certainly I think to most people sounds like, well, if it's a routine thing, I guess it's just carrying on its own. But these are essential vaccines. They are life-saving vaccines, and recovery will require addressing the key causes of disruption during the pandemic. And you see on the right-hand side here, the proportion of countries that are reporting disruptions by different conditions and program-specific services. The immunization program, still 50% of countries as of the end of 2021, were still reporting significant disruptions to this life-saving program. And the reason is that the pandemic disproportionately affected health workers who are so essential to this program. Health-seeking behavior was also negatively impacted as people were nervous to go to receive vaccines at clinics for fear of exposure to COVID. And the implementation of the COVID vaccine program, which was a very high and continues to be a high priority for most countries, was often drawing attention and resources from other services and predominantly the immunization service, because COVID-19 is a vaccination program. That's where the expertise in the countries lived. Next slide, please. And yet, the COVID-19 program has also driven innovations. And these are innovations about taking vaccines to wherever people are at, not expecting people to come to vaccines, using data to guide us on where the vaccines are needed and where the people are who are unvaccinated, and really high-level sustained political commitment and funding. And you'll recognize that each of these things is a core attribute of the polio program. And so there has been an enormous amount of lessons drawn from the way the polio program has reached such success. Next slide, please. And so I just want to really focus on this integrated service delivery, having explained how zero-dose children are not just zero-dose for vaccines, but they live in families that are zero-dose for maternal care, zero-dose for nutritional care, zero-dose for many other services. Integrating services and immunization plus, coming to communities with more than just polio vaccine, more than just immunizations more generally, but coming together with the critical core services that families want. And so the COVID-19 program has been an opportunity to also drive some of the integrated service delivery. As just some examples, in Panama, co-delivering influenza and COVID-19 vaccines. In Sri Lanka, the routine immunization sessions provided an opportunity to screen parents for other services that they needed, including COVID-19 vaccine, and targeting questions to identify high-risk unvaccinated households. In Cambodia, integrating non-communicable disease screening for this purpose. And in Nigeria, taking a whole of family approach, combining healthcare services like child vaccination, malnutrition, screening for NCDs with the COVID-19 services. Next slide, please. And we have amazing opportunities for integration across the life course. There are vaccines that are delivered and for the purpose of protecting health and well-being from pregnancy all the way to older adults. And alongside those touch points across all ages are prevention services for reproductive and maternal health, for water, sanitation, and hygiene, for malaria, hearing screening, HIV, nutrition, neglected tropical disease interventions, and health education, and bundling and integrating these at the level of primary health care is really how we're going to achieve even greater immunization coverage, which is the ambition in order to address the missingness of vaccination that is still present around the world in many countries. Next slide, please. So I want to just end here by saying, what is this really all about? And within the immunization program, we really see from a worldwide perspective and from the Immunization Agenda 2030, the strategy that every country has joined up in and agreed to advance towards the goals for this decade of reducing unimmunized children by 50% by the end of the decade, saving over 50 million lives by the end of the decade. What it's really all about is protecting the adult in every child and the future in every adult with this vaccination across the life course. So I'll stop there and express my appreciation for the enormous contributions of Rotary in so many countries around the world, not only on polio, but to achieve this vision as well. Thank you so much.
Thank you very much, Kate. Stephen highlighted that a vaccine that stays in its vial doesn't have much purpose. And Kate was just highlighting that we have 25 million children in 2021 that didn't receive either their first dose of vaccine or didn't finish their vaccine schedule. And so she also highlighted that these children that miss immunization do not only miss immunization, but so many other services. Just to illustrate that, we're going to watch a video on zero-dose children.
There are 678,290,000-ish children under 5 around the world. But what's so important about being 5? A lot, it turns out. Children who survive to age 5 are twice as likely to reach adulthood. That's why vaccines for young children matter so much. In the last 40 years, global public health infrastructure has reached children here, and even here. Impressive, right? But 12.5 million children in the world are still totally unvaccinated. They're called zero-dose children. Some of these kids are hard to reach because they're living in conflict zones or remote villages. But some aren't that far away, living in dense, low-income urban centers. Essentially, they could be anywhere. Can we really find them? Absolutely. India proved it could be done. In 2009, nearly a third of Indian children under 2 years old were zero-dose children. That year alone, there were 741 reported cases of polio, more than any other country in the world. But with just 1 year of vaccination campaigns that included special strategies to reach zero-dose children, they reduced that number to 42 cases. But how? Well, in some places, vaccinators looked for families at bus and train stations. Others used motorbikes or trekked by foot to find children in the most remote regions. And to tackle 107 city blocks identified as high risk, vaccinators traveled house to house, delivering immunizations for polio and other preventable diseases. Doing this required 4 million vaccine carriers, 5 million vaccinators, 344 million children vaccinated, and 450 million doses of polio vaccine. See? It can be done, and the results are worth it. Let's make sure all children grow up healthy and vaccinated against preventable diseases, and ensure that zero-dose children are a thing of the past.
So to explore what Kate started talking about how we can include other services around immunization, we'll have a presentation on the power of preventive care and community health programs. And this will be delivered to us by Dr. Gitinci Gitahi. Dr. Gitinci Gitahi is the CEO for Amref Amro Health Africa, and he's a renowned leader on the global and regional front with notable achievements, including co-chairing the global UHC 2030 movement, serving on the Commission of Africa's COVID-19 response, serving as a member of the governing board of Africa's CDC, and he was also recently appointed to the board of the Coalition for Epidemic Preparedness Innovations, or CEPI. He also serves on the board of the Standard Group in Kenya and the Board of Trustees of Safaricom Foundation. He's a vocal advocate for pro-poor universal health coverage and leads the largest thought leadership convening on the Africa Health Agenda. Dr. Gitahi, over to you.
Thank you very much, Anshu, and I hope my slides can be seen because I'm pushing them from this side.
Yes, they can.
Excellent. Thank you very much. Thank you, Anshu. My congratulations to WHO and Rotary for the work that you've done in saving children. I think when you look at the success on polio, it is to be replicated across the health system and across the continent and communities. This presentation, I must admit, Anshu, was one of the most difficult ones to prepare. The reason being, I'm not a polio eradication expert. I know that there are many people here who are polio eradication experts who've done great work. And I was trying to see, what really do I need to say that is not known? I've watched the videos, I've listened to everyone, and everyone is talking about the power of preventative care and community health programs. So in a way, I just put in a few thoughts together that may not be related, but I hope at the end of the day, I make the point I want to make. I just want to just show this slide and say, AMREF Health Africa, as you've explained, works across sub-Saharan Africa. That's what we do. We work on healthcare across the continent of Africa. That's where we are limited in about 35 countries. That's all I'll say about AMREF for now. Let me just come back and say that all of us here assembled, what we want is healthy people. But medical science is only one piece of the puzzle. I think that medical science has made great advances. But in many ways, we found that at the end of the day, even with the best available medical science, people and their trust of that medical science and its fit to their lives is actually most important than the medical science itself in many instances. So we always have to put people at the center of the puzzle, and medical science is really just must be acceptable to the people in a way that they find it actually suits their lives. So I just want to give a few examples, and this is why I said, my conversations will look like unrelated, but I'm trying to make the point that people are the center of everything else that we do. I just want to show this framework, which is courtesy of the global health science and practice. And basically all it says, without looking a lot at all the details, is that majority of the people are born healthy. That 85 to 90% newborns are born healthy. And the aim of everything that we do in the health system, the aim of WHO in its strategy, the desire of Rotary, the desire of AMREF, the desire of each of us as an individual is that everybody remains healthy and achieves optimal health. But often there will be instances where people will fall into illness, and our purpose is to get them back to optimal health. So vaccination will be on this side to ensure people are kept optimally healthy. So it will be in this side of health. Water and sanitation, education, ensuring that there is good nutrition will be all targeted to ensure that people have optimal health. But at the same time, we create a system that recognizes that every so often, a small percentage of us, and that's a small percentage of us, will tip into this area of illness. We'll need to diagnose them, we'll need to treat them, and we need to make them recover to go back to optimal health. So we like to say that actually health is made at home, health is made by individuals, but hospitals are garages where when something goes wrong, people are repaired. But we also interface with the hospitals to ensure there's optimal health and maintenance. So what I want to show you with an example of COVID is when medical science is available, what happens when the people are not fully connected to that medical science. This is just a chart that I took when vaccines were finally available in the continent of Africa. Of course, many of us know that for many low-income countries, vaccines were not available for a very long time. There were studies done before saying, would you accept a vaccine if it were available? And we see countries here that show a very high percentage of, yes, I am willing to take a COVID vaccine when it's available. Of course, note that Ethiopia had a very high confidence level, while DR Congo had a very low confidence level. Why so? Because even at a confidence level, even before you talk on the medical science, this reflects the trusts across the ecosystem, the trust of government, the trust of institutions, which is why even us who are working in the ecosystem must first focus on building trust. For polio vaccine acceptance, we have to focus on building trust. When you look at DR Congo, a story is told once, I remember listening to Tedros in a meeting or at in Brazzaville, talking about how WHO struggled to overcome the trust of the system for WHO and others to provide care for Ebola patients. And we remember instances which are not very disconnected with the polio experiences, where health workers were killed hospitals were burnt in DR Congo because they couldn't understand why, there was such a big deal of Ebola, and yet their children were dying of measles. Their children were dying of malaria. Their mothers were dying of pregnancy. All this preventable, but yet there was such a huge effort on Ebola. Why so? And there was such huge resistance, and you can see that even when we came to look at willingness to accept COVID vaccines, DR Congo had the lowest confidence of that. But you can see that Ethiopia had a very high confidence. Why? Because Ethiopia has had a very connected healthcare system, including connecting through community health systems, building what they call community health workers, community health extension workers, who have built confidence in the system, because these community health workers are people who live next door. They're your neighbors. And then they are trained and empowered to understand health systems, and they connect the health system through trust to the people. And you can see that that community health system that was built by the government of Ethiopia are actually reflected in the willingness of people to accept COVID vaccines. But when now the vaccines were available, the confidence was high. Then what happened? So the red bar shows you the vaccination rates in those countries. That actually the delivery then of the vaccines, at the end of the day, even with high trust, dependent on the availability of health systems, universal health coverage, availability of health workers who could actually deliver injectable vaccines. Because even in Ethiopia, the vaccines were actually oral. It's likely that the rate would have been much higher. But these required skilled health workers who are trained and capacitated and allowed by policy to give injectable vaccines. So you can see at the end of the day, countries that are much better health system with skilled health workers, with availability of health facilities, because this is where the vaccines were being given, had a much higher COVID vaccination rate than those that actually didn't, despite having very high confidence levels. So basically saying that robust, trusted, inclusive health systems are the drivers of vaccination and health services. I kind of looked at some raw data to look at how does this vaccine and vaccination relate to other health services. And it's very clear that COVID-19 vaccination rates were actually higher in countries where there was higher skilled health staff across the continent. So you looked at births attended by skilled health staff and COVID vaccination rate, and you saw that countries that had higher births attended by skilled health staff also had higher vaccination rates, meaning there was a direct correlation of vaccination and health system robustness. And two, even if you looked at maternal mortality, countries that had much lower maternal mortality here had actually higher COVID vaccination rate, meaning that for whatever vaccination you're giving, ensuring that it is actually located in a robust health system that is trusted was actually the predictor of success. And the same with with correlation with other vaccines. And this is what Kate was talking about. We had one thing to just share here. We had a case study of vaccination in one of our facilities, which is in a slum area, heavily populated. And we had very low vaccination rates on a daily basis because people were working, people leave and go to work. And this is one challenge we have even in polio vaccination, that if you were to integrate it in the health system, routine, and I had Kate talk about routine vaccination, we find that routine, what we call routine vaccination, which is go to your local facility and get vaccinated, had challenges because most of these routine facilities are open Monday to Friday, and on weekends they're closed. And this is when a lot of the people in the informal sectors, especially low-income countries, where people have to go to be a plumber to earn for their day, to sell vegetables to earn for their day, to feed their children. Therefore, the routinization of vaccination actually meant that it was not mapped to people's lifestyles. So we went and talked to community health workers, go to the communities, talk to people that you talk to every day about hypertension, about diabetes, about family planning, and bring them to the same center on Saturday for vaccination. And we found that around this same facility that was vaccinating only 30 people per day, we were able to vaccinate 365 people in 8 hours. Actually, this was 6 hours because of integrating other services, using community, breaking the trust barrier, getting people to go out and bring the people, and in the same location, in the same community. The last slide I want to share here is integration of health services beyond health. So this activity is held, we've been doing this activity with support of our partners in arid and semi-arid areas in Kenya, where there's a need for access for family planning, there's a need for access for vaccination. But when we go out to these communities, their biggest interest is actually their livestock. So we went out using camels to deliver the services to the people. And every time we found that people are not coming. And we finally, after talking to communities and integrating their needs, we found actually that if you also included animal health and you allow the people to come with their goats and their cows, so that we also carried a veterinarian who would then also give vaccination to their cattle and their goats and give them the services they needed, we found that actually people came for vaccination and family planning in droves because we integrated their needs beyond the health needs. This basically to say that if we actually focus on the household itself in its holistic needs and then map that around the primary healthcare model of ensuring that we are multisectoral, we have empowered communities, and then we provide our primary care essential services around that household, then we succeed. Thank you very much.
So that was a wonderful presentation of practical problems. I like the 10 to 4 approach, which is not the good approach if you want to clean the planet of this terrible disease and others. So thank you very much for that insight into how we should be functioning. Now, it's our great privilege here to have one of the big players of the polio eradication effort, and that's the Bill and Melinda Gates Foundation. And our privilege to have with us here Sandy Lynn. She's Senior Program Officer of the Bill and Melinda Gates Foundation. And Sandy is a public health specialist with over 20 years of regional and cross-regional experience in the international health and development area. She has a country operational experience in more than 20 countries in 6 regions. Her core competencies include communicable disease, HIV, TB, and malaria, technical assistance and capacity development, health system strengthening, health project, and performance-based program management. So thank you very much, Sandy, for giving us your time, and the floor is yours.
Thank you very much for the introduction, and I'm delighted to be part of the World Polio Day and Beyond event here, and I thank WHO and Rotary for inviting me. Can I have the presentation, please? Thank you. So I'd like to talk about connectivity, a bit about from polio to primary healthcare and the broader public health issues such as malaria, and also highlight the power of partnerships. And to do that, I'd like to provide an example of the Rotary program called Partners for Malaria-free Zambia. And this is the first program at scale, and it's a critical partnership that allows for comprehensive interventions. Next slide, please. Just as a reminder, according to WHO malaria report last year, nearly half of the world's population lives in areas at risk of malaria transmission, and that's about 87 countries and territory. A reminder that malaria is still a major public health issue, with 241 million clinical cases and 627,000 deaths, mainly affecting women and children. Next slide, please. So in Zambia, more than 80% of the population is at risk of malaria. This program, Partners for Malaria-free Zambia, is a $6 million three-year partnership with matching funds from Rotary International, Gates Foundation, and World Vision. The program plans to train and support 380 health facility staff and 2,500 community health workers to strengthen the national health system and to expand services to 10 high-burden districts in Zambia. Interventions are based on WHO case management recommendations, and it's implemented by the Ministry of Health, National Malaria Elimination Center, Malaria Partners International, World Vision, and PATH. Next slide, please. So this is a rather complicated slide, but it's basically a summary of the theory of change. So highlighting investments made in community health workers accompanied by adequate commodities to test and treat malaria and other diseases, including pneumonia and diarrhea, and ensuring that communities are trained, behavior change campaigns implemented with the support of Rotarians will decrease malaria cases and deaths amongst pregnant women and children under 5. Next slide, please. This is the result of year 1 implementation, and it shows that more than 1,300 community health workers have been trained across the supported districts in Zambia. This is a remarkable achievement given that the trainings were done during the COVID-19 pandemic, where community health workers were trained with the use of PPEs. There were also, of course, some challenges to procurement and supply chain disruptions, had to adjust the training sizes to comply with COVID-19 safety protocols, so on and so forth. In summary, though, this program demonstrates the degree of public health rigor that Rotary is building into programming. All the data is also reported into the national system. This is also an example of how strengthening the community health systems can address broader health issues. We can't talk about primary health care without really talking about febrile illnesses that is occurring at the community level. Next slide, please. So let me end this presentation with a quote from our malaria program director, Dr. Philip Welkoff, who said, "Rotarians bring unparalleled energy and dedication to global health challenges. Their effort of having brought polio eradication within reach, and I am confident that they will do the same in the fight against malaria." So let me start there. Thank you very much for your attention.
Thank you very much, Sandy. And we have heard from 4 speakers, and we thought it would be nice to have a bit of a discussion with the 4 speakers. And so we'll have the president of Rotary International, Jennifer Jones, will engage the 4 speakers and try to get out some key points in the discussion.
Thank you very much. And thank you to each of the speakers for your wonderful presentations. I think one of the things that we've heard about many of the challenges that are in front of us. And I think in this segment, we're moving toward where is the hope? Where is the hope in how we move forward collectively? And I think also what we're seeing is the transition right now from the conversation that we had yesterday, beginning this morning about polio, but to the broader health infrastructure and what this means to our world. So a couple of questions that I have for each of our speakers today to try and pull together some of where we're going now as we switch towards a focus on maternal and child health and how we create stronger infrastructure across the globe. So Stephen, I'm going to start with you. You talked about vaccine supply, and quite candidly, we know we don't really have a shortage of vaccine supply. Much of it is getting it to people. We heard also, you mentioned, Dr. Kate mentioned, the 25 million that are not vaccinated for essential vaccines. So a challenge, and I want all of these to be action-oriented to what we can do. So what can Rotary members do who are watching today, community at large, to keep encouraging preventative health and vaccine acceptance? We know that this is not just a developing world issue, it is an entire world issue. So how do we increase the vaccine acceptance and encourage this preventative health, which we know is really critical to our entire planet?
Thank you. Rotary can actually do a lot. If I see what Rotary has done in polio, I think there is a world of opportunity there to bring it also to another level for other diseases. A large part of it is to do with investment and where the government puts its money to really see that health of children and adults are improved in countries. And particularly with maternal and child health, I think polio can do what they did Rotary can do what they did in polio, is convince governments that it's important to eradicate polio, convince governments that it is important to invest in mother and child health, and particularly in vaccination in those countries, as we have seen that the investment has gone down over the past years significantly. Keep that momentum to see that these investments are not going down further and that they are restored to the levels they were before and increased in line with the population growth. I think it's also very important what Rotary did in their public communication, in their engagement with the communities where most of the Rotary members come from, to really fight as well this vaccine hesitancy and to see that there is a real uptake of the vaccines that are provided. So there are quite a number of things Rotary can do, can continue doing it and bringing it to another level.
Thank you for that. And I think one of the best parts out of that is it really does accentuate that each one of us as partners brings something unique and different to the table. And that's the strength that we have, having the 1.4 million members across the globe who are able to engage in real time, who are leaders able to create that advocacy and awareness. I also think that shifting toward what you just suggested, how do we take from polio and apply this to other community health initiatives? And Sandy, I just want to move over to you for a second, because we've had a chance, you and I, to be together now multiple times, and the Malaria-free Zambia project, very, very close to my heart, as you know, having spent some time in the field there. This is really a next chapter opportunity in our relationship as partners to take what we've learned from polio and move it into the field. And this community healthcare structure, the 2,500 community health workers, I was in country when the last 100 were being trained, and it was such a beautiful moment to know that we were at that point. It really does mean something to make sure that the community can reach someone in real time. Tell me a little bit about how you see it from your perspective, moving from people having to go to a health center, which is sometimes hours and days away, to having that person right directly in their community, not only for routine immunizations, but for other health initiatives as well. It's a bigger picture initiative. Malaria is one part of it, but it really means so much more, doesn't it?
Thank you. I think you're absolutely right. And communities and community leaders, in fact, play a very important role to bringing different segments of the community together, whether they're local church leaders, school officials, and community activists, etc., or even business leaders, and perhaps even our own Rotary clubs in different parts of the world. They are influential members of community, and they can do a lot to help facilitate activities at the community level. For example, churches are willing to make their premises available for training, and that could be for community health worker training and other training. Community health workers are mostly volunteers, and they are selected within the communities where they live. So there's a lot of trust there. So that also means that they understand the local context and then the needs of the local community. So this also is a big opportunity in terms of making any programs or projects sustainable in the very long term, because they are there, they're living with the communities, and they know what is best for the community.
One of the nurses that I spoke with talked about the fact that this has a trickle-down effect, and that she was so grateful because she was working 24/7 in a community health center and was burning out, had no capacity to actually deal with people day to day. And now that community health workers are there, everyone's sort of staying in their lane, and she's able to do what she needs to do and not taking care of what the community health worker can do. So what a wonderful victory that we're seeing. And one of the statistics out of this that I think is incredibly profound is in the 2 provinces where this pilot is taking place, the mortality rate and the number 1 cause of children dying under the age of 5 is malaria. But I understand that the mortality rate in these 2 provinces has dropped by 50%. This is a huge accomplishment in a very short period of time, isn't it? Yeah. Thank you very much. I want to switch over to Dr. Kate, and a fellow Canadian. Thank you for being here with us today. A joy to be able to see you. I really appreciated your comments about backsliding in immunization. It's a term that I've never heard before. And to hear the percentages that you were sharing with us, going from 86 to 81% in our modern time, how that's so unacceptable that things are happening. I'm going to ask you to sum up, if you would, knowing that we're trying to move to hope and action in this segment. Our greatest challenge, as you see it, our greatest hope, and what we as the Rotary family, and quite candidly members at large of all of our organizations, can best do.
That's a great question. I'm going to start, I think, with the greatest challenge. And I think the greatest challenge is political will. There are so many things that are pulling on our political leaders right now. The world does at times, I think, appear in a number of different dimensions to be a little bit off its axis. And so I think getting the attention and assuring that the immunization and primary health care, and of course the polio ambition, is maintained at the highest possible level. And we have absolutely seen that when ministers of finance and state leaders set their minds to it, that health and particularly immunization can go to the very highest levels of the agenda. And I'll just give a little contrast to just maybe a little sort of thought exercise for those of us in this meeting. I'm not sure that the same hand-wringing is taking place among those who are in the defense sector in many countries. There does seem to be quite a distinction between where the doors are opened and where the check and challenging and prioritization is around sectors. And health, and particularly the areas that we're here to talk about, I think we need to have a greater ambition to assure that political will in every country keeps immunization and keeps health in general, especially primary health care, at the top of the agenda. So I think that's the biggest challenge right now, is to not step back from where this has been for the past couple of years. The biggest hope, I really want to point to community health workers. And I think community health workers are the untested and unexplored opportunity that has not been fully taken advantage of. When I look at especially the zero dose agenda, and you may have noted in the beautiful video on zero dose children, it did cite about 12 million children who are zero dose children, and I gave you a number of 2021 of 18 million. So that number has increased by 50% in a 2-year period. And those are kids year in and year out. It's 12 million this year, another 12 million next year, another 12 million, or in the case of 2021, 18 million. So these numbers of kids grows and grows into an ever greater group of children who are not immunized. And those are the kids, of course, we really try to catch up through campaigns. But I think the community health workers, I think we have to really recognize the community knows where these kids are. The leaders know where these kids are. So it's not a matter of not really knowing where they are. It's a matter of having people at the most local level who are trusted, who can provide the services that people want, and that people will come and receive. And I think it's really important to realize that the main reason why these children are not accessed is not vaccine hesitancy. The main reason that they're not accessed is because the services, the financing, the provision of programs is not where those children are. They can be reached through campaigns. Polio has done that, in a magnificent way through the tremendous efforts that have been made. But that's not a program that will reach them day in, day out as children are born and grow up in their communities. So I think the hope is the community health workers, and that's not only about logistics and incentives. Many, many, many community health workers are not paid professionals. They're not paid for the work that they do. That is an issue that has been on the agenda for a long time and really does need to be addressed. But it's not only that, and I would just leave this area with a couple of points, which is community health workers in themselves are an expertise and have a set of skills that they do that is not the skills that nurses do. It's not the skills that doctors do. And they do need to be at the table for planning, for most local planning, but also for district planning, for country planning. They bring a view and an expertise that is and something in and of itself that other groups of health professionals don't have. So I think my biggest hope here is on community health workers and our ability collectively to take most advantage of what they offer day in and day out, and to accelerate that. Thanks.
Thank you, Dr. Kate. I think it's very interesting. The volunteer nature of the community health worker is an unsustainable proposition. And I agree with you. I think that is the greatest area of hope that we have. But that's probably a next chapter that we need to address in terms of the compensation for these people in the field, because it is an unsustainable proposition. Pride can only last for so long in what it is that they're doing. We have an online question that came in that is very much related to this. And Stephen, I'm going to direct this to you for a second. Dr. Kate touched on it, but the role of government in zero-dose children and the role that they need to play. If you could speak to that a little bit.
Well, the government in the end is accountable for its population, and it's to put that accountability there. And Kate already explained that political will is one of the biggest obstacles we have at this moment, which is related to investments that have to be made in this agenda, but it's also related to exclusion of certain population groups, certain discrimination that is going on against certain population groups that are excluded. We see a very good correlation between zero dose and people that don't have access to any other services as well, and to really point that out to governments to see that this exclusion is solved, because any population that is not vaccinated is also gives also opening to epidemics, to a threat to a larger population in a way or another. And it is a fundamental right for children to have access to basic healthcare, to have access to immunization, to protect themselves against vaccine preventable diseases. So to really point that out, and I think a government has that responsibility, and we can help with realizing that responsibility towards their population.
Thank you. And yeah, it's a basic human right for all people. And it leads me to Dr. Katai, to you as our final question in this session. And disparity. You talked about we want healthy people, everyone, to have the opportunity to live a healthy life. Yet on the African continent, we probably see some of the greatest disparity. And I'd like you to address that in terms of creating more awareness from an action-oriented point. We saw it play out very clearly through the pandemic and through other health initiatives. How do we take better steps to raise awareness, particularly for the most vulnerable?
Thank you very much. And I think you hit the nail on the head that Africa is the most left behind when it comes to health service access. And even within that inequity across the world between Africa and other continents, even within Africa itself, there are countries that are way ahead of others. And even within countries, there are communities that are ahead of others. So the disparities are across between countries and within countries themselves. The issue that we've been raising is about health is a political choice. But that choice has to be made and has consequences as well. And what we have tried to see is how do we actually involve the people to understand that health is a human right, and that right is borne by them, and the duty bearer is their government. And that therefore they have a role to actually actively participate in the choices that their political leaders make on health. And they can make that choice through their civil rights in voting. So we try and make sure that communities understand through the political manifestos in the different countries where they exist. In many countries in Africa, those don't exist as individuals. And the questions that the communities can ask, and even after they have exercised their right, how do we continuously engage and empower those communities through education, showing them what their rights are, how they can actually activate for those rights, working through community grassroots groups, local civil society organizations, which is an area that actually Rotarians can assist with by making sure that in the countries where they're working, they're supporting local organizations with knowledge and means for them to meet their local county assemblies, their local governments, to actually discuss the provision of health, especially the shift of resources from tertiary and secondary care, which is often where politicians are investing their money, and forgetting that the real investment should be at the community level so that you keep people healthy. What we find is that those choices are difficult for politicians because they want to build hospitals, because hospitals are easy to launch in front of the media. It's easy to buy big machines, which are easy to show on TV. But when you invest in community services that are closer to the people, the gains are long-term, and the voting is 5-year cycle. So people are like, let us invest in these big facilities. But those facilities only serve those who are able to go to them, and they leave and they expand the inequities and inequalities that exist in communities. So we have to focus on building local grassroots organizations, enabling them through education to understand their rights, to understand their needs, and to transmit those needs to their politicians so the political choices are responsive to the people's needs. At the end of the day, the choices are difficult because resources are scarce. In Africa, governments are only able to mobilize between $50 and $80 per person per year out of taxes because of the limited fiscal space. Compare that with what's available in the UK, $4,000 of public money a year. Compare that with a country like Malawi, Zambia, and others that are mobilizing only $17 per person per year. Choices then become even more important on where to focus your money and on who, especially those left behind, and how, especially looking at women and girls and children and focusing our political choices on those people, because then that's where we get the big for our dollar. Thank you.
Thank you very much for the very honest answer. And I think that as we wrap up this session, it gives an opportunity to be able to thank all four of our panelists who not only informed us, engaged us, have given us calls to action, and have created an honest environment for us to be able to talk in the next few segments about what we can do to take continued action. We collectively, as we move into the maternal and child health segment, we collectively as the GPEI and other friends who are in the room, we have this opportunity to use our voice very powerfully, and that is our largest call to action out of all of this, to make sure that we are engaging with our friends, with our neighbors, with our community, with our government, as loud as we can. We have the opportunity to make the greatest difference by using and harnessing our resources and our voice. So to each of our panelists, thank you so much for your contributions this morning. They were greatly and are greatly appreciated.
I would like to thank the panelists, and we had really a great morning, but I think we need a break. We need a break. You get 15 minutes. In 15 minutes, you're back, and we continue with the program. Thank you.